Welcome back to the deep dive. Today, we are taking on a source that is, well, it's absolutely foundational, but often the most intellectually challenging part of the surgical syllabus.
Yeah, definitely.
We're talking about Chapter 15 of Baily and Love's 28th edition.
Right.
This chapter is really the conceptual blueprint for the modern surgeon, focusing on human factors, patient safety, and quality improvement.
It's so much more than just an exam chapter.
Yeah.
For surgical trainees, this material, it really defines what it means to be a safe, effective leader of a health system in the 21st century.
I agree.
Your technical skill will absolutely be tested, but it's your systems knowledge that dictates whether you can sustain excellence over a career.
Exactly. So our mission today is to cut through some of that textbook density. This is not a recitation. We're not reading the book to you. This is an interpretation.
It's an analysis.
It's a ready reckoner, really, designed to create some memorable mental anchors, maybe some deep case studies, so that these systems concepts actually stick with you when you're on the ward, in the clinic, or, sitting in an appraisal.
You should absolutely use this as your essential revision tool, but use it alongside the full textbook, which is an excellent resource.
So where do we start? Well, we jump in because the stakes are undeniably high. The chapter sets a pretty sober tone, I think, by acknowledging a fundamental tension.
It does. For the last half-century, medical science has made incredible progress, right? It's dramatically improved public health. But, and this is the big but, that progress has created this enormous, overwhelming complexity.
And that complexity isn't theoretical. It's our daily reality. I mean, we're treating older patients who often present with multiple intertwined comorbidities.
And we have a massive volume of specialized, complex, and let's be honest, expensive treatment options that just didn't exist even a generation ago. And that's where the system starts to break down. I mean, the source material is brutally honest about this. Implementing complex, evidence-based care in these large hierarchical health systems is just incredibly challenging.
So patient satisfaction and safety are frequently compromised.
They are. It's due to poor organizational integration, fragmented resource use, and, at the end of the day, human error.
So we've created better medicine, but somehow worse delivery. Is that what we're saying?
Often, yes. In some ways, yes. And we see the consequences in the workforce. I mean, the chapter highlights the challenge of supporting staff against burnout.
Which comes directly from that complexity.
It does. It stems directly from that increasing complexity and the excessive administrative workloads required to manage it all. I think the biggest challenge of this decade is promoting value while simultaneously supporting the staff to deliver high-quality, safe care without succumbing to exhaustion.
And to really get to grips with this, the key intellectual foundation, the thing you have to understand, is the influential Institute of Medicine report, Crossing the Quality Chasm.
That report was a game changer. It fundamentally told the world that patients, even in advanced settings, often don't receive the right care at the right time or, in the right place.
Right.
And that realization, that single realization, it necessitated a root and branch redesign of healthcare processes and systems.
Yeah.
It was a shift from a culture of sort of individual heroics to one of systemic standardized safety.
It basically recognized that our medical capability had just completely outstripped our delivery efficiency.
Exactly.
So if the quality chasm demands the system redesign, where do we actually start building?
Well, you start by defining success.
But not in volume,
Right.
In outcomes. And this introduces Professor Michael Porter's concept, a really crucial framework for modern health systems, value-based healthcare.
Right. And value here is a function, it's a simple equation. The outcomes delivered to patients relative to the total cost of care.
See, that's a huge difference.
It is. It shifts the focus away from just high volumes of activity. Lots of procedures, lots of admissions, and it forces us to focus on health, on well-being, and genuine preventative care. It's a much more holistic view.
Okay, let's anchor this with a powerful mental model. We're calling it the metaphor anchor, healthcare as a business ecosystem.
I like that.
Porter, who's a prominent economist, he essentially applied the concept of competitive strategy to healthcare. He argued that if we structure the entire ecosystem around delivering maximum value to the patient, the whole system, including its costs, just becomes more efficient and effective.
But there's a critical question there, isn't there? Does this move toward value-based care risk being driven primarily by cost reduction rather than pure patient benefit?
That's the pushback, yeah.
It is. And it's the critical dialogue we need to have. But the answer, according to the framework, is that true patient benefit is cost reduction. Because efficient, effective care avoids expensive readmissions, complications, and litigation. If the outcome is good, the total cycle cost is very often lower.
So he proposed 6 foundational principles to get this done, the pillars of value. And these are really high-yield points for any trainee trying to understand system leadership.
Okay.
First one, organize care around medical conditions.
So this means care should be structured around the patient's needs for that specific condition, say breast cancer or a complex hernia, not just around traditional departmental silos like radiology or general surgery.
It's about multidisciplinary team.
Exactly. Coordinated pathways from diagnosis all the way through recovery.
Okay, second pillar, and this one lays the groundwork for all quality improvement, is the mandate to measure outcomes and costs for every single patient.
If you don't have that accurate, granular data on what you're spending and what you're actually achieving in health status, you just cannot possibly identify inefficiency or waste. It's impossible.
Right. Third, align reimbursement with value.
And this one is a powerful lever for change. It aims to reward better, more efficient outcomes, rather than just paying for the volume of procedures performed.
Fourth is systems integration. So organizing treatment pathways by matching the patient, the treatment, and the best location, ensuring patients aren't just bounced between unlinked care sites.
Then the fifth is geography of care.
Centers of excellence.
Precisely. Creating specialized centers for highly complex or rare procedures, making sure patients are treated where expertise is concentrated and outcomes are maximized.
And finally, the sixth pillar, information technology or IT integration.
This is everything from, universal standardized healthcare numbers to seamless interoperable IT platforms. And the source acknowledges that while these ideas started in the U.S. private sector, public systems like the NHS are steadily adopting these core concepts.
So Porter tells us how to redesign the structure, but human factors tells us how to optimize the human beings operating within that structure.
Yes. Human factors, or HF, is a multidisciplinary science. It examines the behavioral interrelationships between humans, their tools, and their environment.
So that includes everything: teamwork, communication,
The design of the physical workspace, the equipment you use, and the underlying institutional culture. It's all connected.
And we have to be really clear here. The ability to execute a difficult technical maneuver, your anatomy knowledge, your suturing skill, that's just the minimum entry requirement.
Right.
HF focuses on the crucial non-technical skills, the cognitive and the interpersonal skills you need to manage team-based, high-risk activities.
And we can trace this discipline back to a really powerful HF origin anchor, the cockpit analogy.
Aviation.
Exactly. HF training started in the high-stakes, high-risk aviation industry in the 1940s. Aviation realized that most disasters weren't caused by technical failures. They were caused by coordination and communication breakdowns between highly skilled people.
And they defined 2 core skills they needed to teach. First, cognitive skills.
Right. These are the mental processes happening internally. You're constantly maintaining situational awareness, solving novel problems under extreme pressure, making rapid, high-stakes decisions with incomplete information.
It's like your mental checklist and your ability to forecast what's coming next.
It is. In contrast, interpersonal skills are external and relational. They're the communication strategies and behavioral activities that go with effective teamwork. How you assert yourself, how you listen, how you provide cross-checks, how you lead in a crisis.
And that realization led directly to crew resource management, or CRM, training.
CRM is designed to build a cohesive environment where everyone, and I mean everyone, from the most junior circulating nurse to the most senior consultant, feels psychologically safe and empowered to speak up when they suspect a problem.
Non-judgmental error addressing.
Yes. Formal cross-checking, mandatory debriefing, and feedback. And CRM is also the mechanism for managing fatigue, stress, and correcting perceptual errors.
But in a traditional, hierarchical, and time-pressured surgical setting, how realistic is it to achieve that true non-judgmental error addressing?
Well, that is the challenge, isn't it? The source implies that it requires a constant effort by leadership to cultivate that culture.
So a highly skilled technical surgeon who has poor CRM, who is dismissive or intimidating, they become a system risk.
A huge system risk.
Yeah.
Because they actively block the team's collective ability to catch a downstream error. CRM teaches that leadership is a shared responsibility, not just about who's holding the scalpel.
And these HF concepts have now moved into system design itself, which brings us to a more modern concept, nudge theory, pioneered by Richard Thaler and Cass Sunstein.
Nudge theory is basically behavioral economics applied to systems. It involves shaping the environment, the architecture of the choice, as they call it, to encourage decisions that benefit the individual or the organization, all while keeping that individual's ultimate freedom of choice.
It uses the default setting as a really powerful lever.
Exactly. Let's use a clinical application beyond the textbook example. So think about the infection control pathway for placing a central line. If the standard tray is designed so that the protective barrier, the drape, is physically the very first item the operator sees and has to touch before they can even reach the insertion equipment.
Nudging them.
You are nudging the clinician to use it first. You're making the safest choice, the easiest choice.
And the classic example cited in the source really reinforces that value principle. Designing electronic medical records, so the default setting is to prescribe generic medication brands.
With a simple opt-out checkbox for the prescriber. It just subtly reinforces cost-saving efficiency and standardization without taking away the clinician's ultimate freedom to choose what's best for their patient.
Okay, before we move on, let's just do a quick check-in. If a surgical team member fails to notice that the patient's initial blood pressure was recorded incorrectly in the chart because they were focused entirely on placing the lines, is that failure primarily a lack of a cognitive skill or an interpersonal skill in the context of CRM?
That is primarily a cognitive skill failure, specifically a failure of situational awareness. They were so focused on the technical task that they failed to scan their environment and register critical changes in the patient's data or surroundings.
Okay, so if those terms are still a bit hazy for you, just rewind and listen to that aviation analogy again.
So the key takeaways from this first section. First, value-based care is centered on measuring health outcomes relative to costs. Its 6 pillars demand systemic integration, not siloed activity.
Second, human factors is all about cognitive and interpersonal skills learned via CRM training, and it's absolutely essential for optimizing these high-risk, team-based environments.
And third, CRM emphasizes empowering the entire team, regardless of hierarchy, to speak up and cross-check actions. And that is the necessary cultural shift required by that quality chasm we talked about.
Now we have to confront the sobering reality that despite our best intentions, despite our ethical commitment to primum non nocere first, do no harm medicine will never be risk-free.
It won't. And the data on error forces us to adopt the system approach we're about to discuss.
The scale of the problem is just enormous. The U.S. Institute of Medicine's huge report, To Err is Human, that really brought this issue into the public eye.
And the WHO estimates are stark. I mean, even in advanced high-resource hospital settings, 1 in 10 patients receiving healthcare will suffer preventable harm, often leading to temporary or even permanent disability.
And the financial scale is just as compelling.
It is. The OECD notes that iatrogenic patient harm caused by the medical intervention itself, is not only the 15th leading cause of global disease burden, but it accounts for roughly 15% of all hospital expenditure across member countries.
And that cost is driven by longer hospital stays, remediation, litigation.
Exactly. Prolonged hospitalization, disability payments, litigation. This is not just a clinical issue. It's a massive global economic and social challenge.
So to manage this unavoidable risk, institutions need these robust, comprehensive risk management systems. And it's not just about avoiding litigation, is it?
Not at all. It must encompass IT integrity, cybersecurity, regulatory compliance, but our focus here remains on clinical risk. And that has to be carried out in a blame-free environment to maximize institutional learning.
The clinical vocabulary is essential here. We differentiate incidents along a spectrum based on whether harm actually occurred.
Right. So first you have an adverse event. That's a preventable event that results in actual harm to the patient.
Okay, actual harm.
Then you have a near-miss event.
Yeah.
Here, an error occurs, but due to chance or a timely intervention, say, a nurse catching an incorrect drug, it causes no harm.
Ew.
And finally, a no-harm event. This is where the mistake reaches the patient, say the wrong dose is ordered, but results in no harm because of mitigating circumstances. Maybe the patient's underlying physiology compensates.
And when we look at the factors that contribute to these incidents, the data from Table 15.1 in the source is, well, it's very telling.
It is. Under the category of system failures, the single most frequent contributing factor cited globally is inadequate communication.
Not equipment failure, not staffing. Communication.
Inadequate communication between staff or between staff and patients or their families. It consistently sits above problems like inadequate staffing, lack of coordination at handovers, or equipment failure. It perfectly justifies why the investment in CRM and interpersonal skills is so foundational to safety.
So when an error does happen, how do safety professionals analyze its cause? They view it through two fundamental lenses.
First, there's the person approach. This is the intuitive one. It focuses on individual fallibility, the tired doctor, the distracted nurse, the hurried surgeon.
Right.
Errors can be of commission, so doing the wrong thing, omission, failing to act, or execution, doing the right thing incorrectly,
But the problem with the person approach is it defaults to blaming the individual.
which just stops the system from learning. Nobody's going to report a failure if they fear punishment.
In contrast, we have the system approach. This is far more sophisticated.
It is. It recognizes that in complex health systems, adverse events rarely have a single isolated human cause.
So after influential analyses like the 2013 Berwick report, the emphasis shifted dramatically.
It did. It shifted to examining why the systemic environment, the processes, or the latent conditions enabled the mistake, rather than just asking who made the mistake.
But the psychological barrier to adopting that approach is immense, isn't it?
It's huge. It's so much easier to blame an individual and fire them than it is to redesign an entire hospital's EMR system or change the culture of a surgical department.
Right.
But the system approach insists that if you don't fix the underlying conditions, the next highly skilled person who replaces the blamed individual will eventually make the exact same error.
And this philosophy led to two critical conceptual anchors. Let's start with a newer one, safety 1 versus safety 2.
Okay, so safety 1 is the traditional reactive model. It focuses entirely on failures. You identify errors after the event, you seek the cause, so you can prevent it from happening again. The question is purely, why did it fail?
But safety 2 is the fascinating proactive addition. It acknowledges that staff are constantly innovating, adapting, improvising, just to keep things running smoothly, often despite poor system design.
It focuses on resilience. The question is flipped. Why does performance succeed so much more often than it fails? Safety 2 tries to study and enhance the capacity for effective, resilient performance. It's about understanding work is done versus the idealized work is imagined.
We also have the foundational concept of Heinrich's safety pyramid.
This is a powerful statistical model. It proposes that for every one major injury, the event at the very top of the pyramid, it's typically preceded by dozens of minor injuries and potentially hundreds of near misses, which form the wide base.
So the implication is clear. If you robustly capture and analyze all those near misses and minor incidents at the base,
you learn enough to install barriers that prevent the rare catastrophic events at the apex. It stresses that reporting even the smallest potential defect is vital risk management.
But the most famous and widely used safety model has to be Reason's Swiss cheese model.
Right. So think of the system's defense's staffing levels, standardized protocols, equipment maintenance, checklists, as multiple slices of Swiss cheese stacked together.
Okay.
Each slice represents a layer of defense, but each slice has random defects or holes. And harm, the adverse event, it only occurs when the holes in all the layers of defense perfectly align.
Creating a direct pathway for the accident trajectory to reach the patient.
Exactly.
Okay, let's slow down and dissect that alignment with a case study. Let's call it the misaligned holes.
Okay, so we have that 70-year-old patient admitted for an urgent hernia repair with a documented penicillin allergy. The latent conditions, the system holes, are built into the environment before the patient even arrives.
For example, latent hole A. The hospital culture is one where senior staff implicitly rewards speed over thoroughness, creating time pressure.
Right. And latent hole B. The EMR system is slow, it's not intuitive, and it requires multiple confirmation clicks, which makes allergy checking a really onerous task.
Then the active failures, the person holes, come into play on the day of surgery. Active hole 1. A severely fatigued junior doctor working a punishing schedule forgets to double-check the preoperative orders because they're focusing on a complex discharge summary.
Okay. And active hole 2. The EMR system times out because it's so slow, and the nurse tasked with medication administration bypasses a crucial allergy confirmation pop-up because they feel pressured by the running list.
And then active hole 3. We get to the timeout on the WHO checklist, which should be the final critical barrier. But the senior surgeon is annoyed by the delay and cuts the process short.
So they allow the team to skip the verbal confirmation of the allergy status, saying, "We are ready, let's go."
The prophylactic antibiotic is administered, and the patient suffers severe anaphylaxis. No single person caused that harm.
No. The adverse event resulted from the poor design of the EMR, that's latent B, compounded by fatigue, active 1, time pressure, active 2, and the failure of the final safety barrier, the checklist culture, active 3.
The takeaway is profound. Good systems require multiple redundant functional barriers to prevent that alignment.
Okay, a quick check-in. If a hospital decides to invest a massive amount of capital in replacing all its outdated equipment, ensuring that no machine ever malfunctions again, which type of hole In the Swiss cheese model, are they trying to eliminate latent conditions or active failures?
Hmm. Primarily, they're trying to eliminate latent conditions. Those are the system defects that are present but dormant.
Exactly. By eliminating unreliable equipment, they remove one major hole in the cheese slice, making it much harder for a sequence of active human failures to lead to harm.
So the key takeaways for this section.
Yeah.
First, the system approach focuses on why the failure happened, recognizing that the overwhelming majority of errors are system-based, not person-based.
Second, the Swiss cheese model illustrates that harm requires multiple concurrent failures, and system safety depends on creating those redundant barriers.
And third, near misreporting is vital thanks to Heinrich's pyramid, and inadequate communication is the single most frequent contributing factor to all these incidents.
The theoretical models are crucial, but how do we translate them into practical daily safety strategies?
Well, we start with standardization, which was driven globally by the WHO's second Global Patient Safety Challenge, Safe Surgery Saves Lives.
This initiative fundamentally changed surgical practice worldwide, and its main output was the Surgical Safety Checklist.
And the evidence supporting this simple tool is just overwhelming, isn't it?
It really is. The source material references critical studies showing that proper, consistent implementation was associated with a near halving of perioperative mortality, from 1.5% down to 0.7%,
Wow.
and a significant reduction in major inpatient complications from 11% down to 7%.
And this effectiveness was proven universally. It wasn't just in advanced settings.
No, in both low-resource and advanced settings. The source cites the 2015 Norway study, which confirmed complications fell substantially alongside a significant fall in hospital mortality.
Yeah.
You just can't argue with that data.
And the elegance of the checklist lies in its simplicity. It requires specific verbal checks at 3 obligatory time points. It forces the team to pause, communicate, and confirm critical information.
Right. First, before induction of anesthesia, that's the sign-in.
Then, before the skin incision, the timeout.
And finally, before the patient leaves the operating room, the sign-out.
And that timeout is the final physical barrier. It ensures all team members stop and verbally confirm the patient, the site, the procedure, all the critical steps right before the scalpel touches the skin. It's your last chance to prevent a never event.
But, and this is the critical warning the source provides, checklists are powerful tools, but they are not a complete solution. A checklist is a simple reminder of what is already known. But if a surgical team starts to believe that safety is simple and only requires filling out the form, they risk abandoning the deeper cultural efforts that are required by CRM and systems thinking.
So, implementation requires more than just compliance. It demands a real attitude change. So what are the success factors?
They're all about culture and leadership. Early staff engagement, the people who use it must help design it. Active leadership and champions to enforce it.
Extensive training and education.
Mandatory multidisciplinary involvement, anesthetists, surgeons, nurses, they all have to commit. Coaching and ongoing feedback through debriefing.
And remember that data point from Section 2. Between 53 and 70% of surgical errors occur outside the operating theater.
Yeah, and pre-assessment on the ward during discharge. The safety effort has to target the entire surgical pathway, not just the 2 hours spent in theater.
So, moving from global standards, we look at how institutions and individuals manage quality. And this brings us to clinical governance.
High-performing institutions are characterized by transparent governance structures that provide robust oversight for everything.
From patient safety and risk management to business planning and outcome reporting.
Right. And the people within those governance structures must operate with unshakable professionalism. This refers to the behaviors and attitudes that place the patient's best interests above everything else.
Which ties directly into maintaining fitness to practice.
Yes, ensuring the individual possesses the necessary knowledge, skills, and, critically, the right attitude. And the responsibility for monitoring this fitness is distributed across the individual, the employer, and professional bodies.
Often using things like credentialing to ensure a surgeon is appropriately trained and monitored for specific complex procedures.
And outside the OR, the bedrock of both professionalism and safety is communication, particularly around informed consent.
We know poor communication is a major driver of litigation.
The goal is to involve patients as genuine partners in their care, and it is absolutely vital to recognize that consent is a deliberate, required process. It's not a hurried, single event.
It takes skill to explain the complex trade-offs between potential harm and benefit.
Especially since patients vary so wildly in their existing perception and understanding of medical risk. a failure to provide adequate time for discussion, or the misunderstanding that a signature on a form equals satisfactory consent. These are frequent causes of an unsatisfactory process.
So to anchor this, let's detail the 6 core pieces of information required for informed consent, as listed in Table 15.2.
Okay. 1. Clear explanation of the patient's condition and why surgery is necessary. 2. The specific type of surgery proposed in language they can understand.
3. The anticipated prognosis and the expected side effects. 4. A discussion of the unexpected hazards, the risks, both common and rare.
5. All alternative and potentially successful treatments, including non-surgical options. And 6. The consequences of choosing no treatment at all.
But despite all the best efforts, adverse events happen. So the professional, and in many places the statutory response to this crisis, is open disclosure, or the duty of candor.
This duty, which was codified in the UK since 2015 after the Francis Report, it mandates radical transparency after an error. When an adverse event occurs, the duty requires the healthcare provider to provide a full and honest explanation of what happened.
And detail the potential consequences.
Outline the plan to fix the problem and sincerely offer regret or an apology.
This is a powerful demonstration of professionalism. Failure to adhere to the duty of candor turns a technical mistake into a failure of trust, professionalism, and a serious legal risk.
And while the focus is rightly and primarily on the patient, the first victim, we must also acknowledge the staff. This introduces the concept of the anchor, the second victim.
This concept acknowledges the severe emotional, mental, and physical trauma that surgeons and healthcare workers often experience after being involved in an adverse outcome.
They may suffer from PTSD, depression, self-doubt. Comprehensive risk management systems must not only be patient-centric, but must also proactively acknowledge and support the resilience and well-being of the workforce.
Let's revisit an example of an adverse event. An iatrogenic bile duct injury that occurred during a laparoscopic cholecystectomy. Harm resulted from the intervention, an executional error, perhaps due to misidentifying anatomy.
Right, so the surgeon now has to explain this catastrophic injury to the patient and their family.
How does the duty of candor guide that emotionally wrenching conversation?
It demands total honesty, even when it's painful. The surgeon must explain, in simple terms, how the injury occurred, not deflecting blame, but explaining the process failure.
They have to explain the future plan.
Exactly. Whether that involves immediate surgical reconstruction or transfer to a specialized center. And crucially, they must apologize sincerely for the unintended harm. This transparency preserves integrity and trust.
Okay, so a quick check-in. Why are safety champions and visible leadership so critical to the success of the surgical checklist beyond just enforcement?
Well, because the checklist represents a cultural change, not just a procedural change. If the leaders, the senior surgeons, don't use the checklist seriously and consistently, the team sees it as a bureaucratic hurdle that can be skipped under pressure.
Which fundamentally undermines its effectiveness as a safety barrier.
Exactly.
So, key takeaways for this section. The WHO checklist is profoundly effective, but implementation hinges on culture and leadership, not simple adherence.
Consent is a structured process requiring 6 core disclosures. And open disclosure, or duty of candor, is a mandatory ethical and statutory response to error.
And we must simultaneously master situational awareness, emotional intelligence, and recognize the need to support the second victim after critical incidents.
So now we drill down into the operating theater itself, which the source described as being among the most complex political, social, and cultural structures that exist.
In this high-stakes environment, the advanced behavioral skills we introduced earlier, they become mission-critical.
Right. Situational awareness, or SA, is more than just observing. It is the continuous process of perceiving elements in the environment, understanding their meaning, and projecting their status into the near future.
So a failure of SA might look like a surgeon fixating entirely on a difficult bleeding point in the wound,
while failing to register verbal cues from the anesthetist that the patient's core temperature is dangerously low or that the blood pressure is trending down.
An SA is inextricably linked to emotional intelligence, or EI.
Yes. Solovey and Mayer defined EI as the ability to monitor one's own and others' emotions, to label them appropriately, and to use that information to guide thinking and behavior.
So a surgeon with high EI can recognize their own mounting stress level and adjust their pace.
Or recognize the anxiety in a scrub nurse's voice and understand that it signals a potential problem with equipment.
And why these skills are so vital is underscored by the occupational health risks. Burnout, emotional, mental, physical exhaustion from prolonged stress is rampant.
It is. And doctors, particularly surgeons, suffer from it more than many other professions. The link is direct and dangerous. Tiredness and high stress are proven to correlate with lapses in judgment, reduced situational awareness, and an increase in medical errors.
And the chapter specifically attributes this exhaustion to a lack of autonomy and increased administrative workloads.
Citing the burden of complex electronic record-keeping systems. And this fatigue problem forces us to return to that unique challenge in surgical training systems we mentioned earlier, the trade-off conundrum.
Leadership has a responsibility to reduce resident working hours to minimize fatigue. That's a system improvement designed to close a latent hole in the cheese.
But reducing hours necessitates more shift work and more clinical handovers, which introduces a new system risk. A new set of potential holes, reducing continuity of care and creating fertile ground for communication errors.
It's a profoundly difficult balancing act.
It is. So to mitigate the constant cognitive load in this stressful environment, the surgeon strives for proficiency, an acquired state honed by sound teaching, practice, and repetition, leading to consistently good outcomes.
And proficiency reflects a deep psychological shift in how the brain processes complex motor and cognitive activity. We can anchor this with the pyramid of competence from figure 15.4, which describes the learning curve.
Right, so the base starts at unconscious incompetence, where you don't even know the skill exists, and it progresses to conscious incompetence, where you recognize the skill, but you can't perform it.
But the critical phase is the jump from the middle to the top. When a trainee reaches conscious competence, they can successfully execute the operation, but it requires conscious control processing.
Execution is slow, it's deliberate, it requires constant tiring attention, and every step is a deliberate mental calculation. The operation is good, but it's exhausting.
In contrast, the expert operates in a state of unconscious competence. Execution is effortless, intuitive, and untiring.
This is automatic unconscious processing. I mean, think of an expert surgeon tying a knot. They don't think about the steps, they just do it.
And the transition between these two states is the surgeon's learning curve. Understanding this helps the trainee accept that their slow, deliberate effort is a sign of competence, not failure.
Exactly. Speed and flow will only come with that automaticity.
Yeah.
But even experts are fallible. Sir Alfred Cassieri defined coal-face errors that surgeons are prone to.
And these categories are really high yield for clinical scenario analysis. Diagnostic errors, resuscitation errors, prophylaxis errors, prescribing errors, teamwork errors.
And of course, technical or operative errors. And within those teamwork failures, we find the most catastrophic events, the never events.
These are errors deemed wholly preventable, requiring robust systemic protective barriers.
And these failures, the wrong patient, wrong site, wrong procedure, a retained instrument, they almost invariably occur through a breakdown in communication, compounded by latent system failures.
The image in the source, figure 15.2, showing an MRI of a retained surgical swab diagnosed 10 years later, is a visceral reminder of what a catastrophic system failure looks like.
And finally, we have to dissect technical and operative errors, where the person approach sometimes carries more weight, even while acknowledging the system context. The surgeon retains specific accountability during the operation itself.
So these failures fall into distinct categories. First, cognitive errors of judgment.
Like making the late decision to convert a difficult laparoscopic procedure to an open one, or failing to appreciate critical anatomy that's obscured by inflammation.
Then procedural errors,
where the steps of an operation are omitted or executed out of sequence. For instance, forgetting to check the correct insertion angle of a cystic plate during a complex liver case.
And finally, executional errors.
Doing the right step incorrectly. For example, using too much force during dissection, or applying an energy device like diathermy in an inappropriate location, causing an injury like the bile duct injury we discussed.
So, if a trainee performs a complex skin graft procedure perfectly, but takes 3 times longer than the expert because they have to consciously think about every single suture placement and tension adjustment, what state of the pyramid of competence are they operating in?
They are operating in conscious competence. They are technically sound, but the process is slow, deliberate, and tiring because they're still relying on conscious control processing rather than effortless automaticity.
Okay, so key takeaways for this section. Situational awareness and emotional intelligence are the cognitive tools that minimize error, but they are compromised by high rates of burnout.
Surgical competence is a progression from tiring conscious control to effortless automatic processing.
And technical errors fall into distinct addressable categories, and never events demonstrate absolute system failure.
So we have defined the problem, the poor value, the complex system, and the risks. the human factors, the error models. Now we arrive at the structured science for continuous self-correction, quality improvement, or QI.
And QI is defined as the continuous, intentional, and combined effort of people to make changes that lead to better patient outcomes, enhanced system performance, and better learning.
And this process is entirely dependent on data. Improvements don't happen by intuition or hope. They require staff equipped with specific QI skills and fundamentally accurate measurement.
This is where we have to reference the great data gurus, Deming. In God we trust, all others bring data.
Drucker. What gets measured gets improved.
Mm.
And Berwick described the predictable four-stage sequence of institutional resistance to data.
Which is what?
First, the data are wrong. Then, the data right, but it's not a problem. Then, it is a problem, but not my problem. And finally, hopefully, I accept the burden of improvement.
And the formal process of checking performance against established norms is clinical audit.
Right, a core function of clinical governance. This is how current care is compared against accepted standards. It's a quality assurance check. High-value QI, or audit activity, follows a cyclical, four-stage structure.
Preparation and planning.
Measurement of performance.
Implementation of change.
And sustainment and evaluation. Did the change stick and result in long-term improvement?
So if data is king, we need to know what three categories of measure to track.
First, structural measures. These describe the static characteristics of the health system or its resources, the what you have.
Like the number of beds per capita or the presence of standard operating procedures?
Exactly. They're very useful for evaluating the equity of access to healthcare across different regions.
Second, process measures. These assess what the provider did and how well it was done, the implementation of procedures.
And the aim here is to reduce inappropriate variation in execution. A great surgical example is tracking operating list start times or the percentage of patients getting prophylactic antibiotics at the right time.
And third, outcome measures. These describe the effects of care on the patient's health status.
While traditional outcomes include things like mortality and complication rates, the gold standard is the PROM, the patient-reported outcome measure.
Which focuses on outcomes that genuinely matter to the patient.
Like quality of life, pain scores, or return to full function, rather than just provider-centric metrics. This emphasis on the patient perspective is formalized in patient-centered co-design, working with patients as genuine partners to identify and prioritize desirable outcomes.
And QI is so necessary because the pathway from illness to wellness is an organizational marathon. I mean, if we map the typical elective pathway,
You see potentially dozens of handoffs: referral, consultation, pre-assessment, admission, pre-op checking, theater, ward, discharge.
and the urgent or emergency pathway adds even more layers of high-stakes, rapid decision-making.
The conclusion is inescapable. The sheer number of individual interdependent steps creates almost limitless opportunities for errors, delays, and organizational inefficiencies. QI methodologies provide the disciplined tools to analyze and improve every single step in that complex surgical pathway.
Okay, let's provide some memory anchors for the major QI frameworks, which act as the tools for driving structured change.
The most common and accessible is the model for improvement, based on Deming's work. It forces simplicity by asking three questions. What are we trying to accomplish? How will we know it's an improvement? And what changes can we make?
And the practical mechanism of this model is the anchor. PDSA cycles, Plan, Do, Study, Act.
It's the scientific method applied to process improvement, small, rapid cycle testing. You plan the change, predicting the outcome. You do the test on a small scale. You study the data, did it work? And you act by either adopting, adapting, or abandoning the change.
So let's walk through a quick PDSA cycle for improving theater start times.
Okay. Plan. We predict that introducing a mandated 5-minute pre-list huddle will reduce delays caused by missing equipment.
Do. We test this huddle for 2 days on one specific surgical team.
Study. We measure the start times and specific causes of delay over those 2 days, comparing them to the previous week's data.
And act. If the data shows a reduction in equipment-related delays, we standardize the huddle process and spread it to other teams.
Then we have lean methodologies, which originated in Japanese manufacturing at Toyota. And they emphasize Kaizen, or continuous improvement, through the relentless elimination of waste.
And the key anchor here is recognizing the 7 forms of waste in healthcare. Recognizing these is so high yield because they are everywhere.
First, overproduction. Ordering unnecessary pre-op blood tests or imaging.
Second, inventory. Storing excess supplies that clutter space, expire, or hide defects.
Third, waiting. Patients waiting long periods for theater lists, diagnostics, or consultations.
Fourth, transportation. Unnecessary movement of patients or materials.
Fifth, overprocessing. Using a complex, expensive CT scan when a simple ultrasound would do.
Or having redundant paperwork steps.
Exactly. Sixth is defect. Clerical errors, incomplete consent forms, or surgical site infections.
And seventh, motion. Staff constantly searching for necessary drugs, equipment, or instruments because of unstandardized layouts.
The power of lean is understanding how they connect. For instance, overprocessing, like running unnecessary tests, creates waiting for the patient and increases the potential for a defect, like a clerical error in the lab ordering system.
So targeting one waste often shrinks others.
Precisely. A third framework is Six Sigma, a highly measurement-based strategy focusing on reducing unnecessary variation. It uses the DMAIC system to find, measure, analyze, improve, control. Where lean is about speed and reducing waste, Six Sigma is about precision and predictability.
And lastly, remember the clinical microsystems, the small, multidisciplinary teams who work together to provide specific care, like the endoscopy team or the vascular clinic.
They are considered the fundamental unit of quality improvement within a large organization. They act as living adaptive systems.
But to make any of this work long-term, you need an overarching philosophy, systems thinking.
This means abandoning the focus on isolated functions and considering the whole system and the complex relationships between parts. You cannot optimize surgery without considering its deep interdependencies with pre-assessment, anesthesia, critical care, and logistics.
And systems work best when they have visible leaders who understand this complexity.
Leadership must foster a non-punitive culture, respect individuals, champion continuous QI, and maintain a constancy of purpose that centers on creating value for the patient.
The source notes that healthcare has historically been slow to adopt QI compared to sectors like automotive or tech.
But success stories, like the Virginia Mason Medical Center, they prove the massive potential. Quality improvement must be at the very heart of medical training. Understanding how to implement evidence-based practice in complex settings is no longer optional. It is an essential skill for every surgeon.
Okay, a quick check-in. A surgical team decides to apply lean principles to reduce motion waste. They reorganize the theater layout so all emergency drugs are always in the same standardized location, eliminating searching time. Which type of quality measure will best confirm that this intervention was successful? Structure, process, or outcome?
That would be a process measure. Specifically, tracking the time taken to retrieve an emergency drug pack, proving that the procedural flow has been improved. The standardized layout itself is the structure measure.
Okay, so key takeaways for this final section. QI is a structured, intentional process of continuous change, requiring data measurement and guided by the model for improvement.
Quality is measured by structure, process, and outcome, with PROMS being the ideal outcome metric for patient-centric care.
PDSA cycles, Lean 7 Wastes, and Six Sigma DMAI are the core methodologies for driving sustainable change.
And systems thinking and humble, visible leadership are essential for long-term improvement across the entire surgical pathway.
And that brings us to the end of our deep dive into Chapter 15, a truly crucial area that bridges clinical practice with organizational leadership. We move from the macro challenge of defining value through human factors and safety, analyzed error models like the Swiss cheese, and ended with the structured science of quality improvement.
The knowledge in this chapter is precisely what elevates a technically capable surgeon to a true leader of surgical care pathways. Understanding the system and the cognitive and interpersonal skills required to influence it is now just inseparable from technical mastery.
We discussed a major, difficult tension in this chapter. The necessary trade-off between reducing resident working hours, which is an effort to mitigate fatigue, and the resulting requirement for more clinical handovers, which create new system risks.
So here is our final challenge to you, the learner. Given that no system is ever perfect, how would you specifically redesign a surgical team handover system, applying the principles we discussed? Which of Lean 7 wastes would be your primary target in this new system?
And how would you use the Swiss cheese model to build redundant communication barriers into that process?
Furthermore, if you implemented this new system, what new data, a structural, a process, or an outcome measure would you need to track to prove your intervention was genuinely an improvement, not just a change?
Think about that question. Using all the anchors we've covered today, the next time you step onto a ward or into a clinical meeting, apply these systems concepts to your next clinical rotation.
Thank you for joining the deep dive.